You're live now, Chair.
Thank you. Morning, colleagues. We are now streaming live our place board meeting. So very welcome on this first Wednesday in February. Just as a starter, I think public and patient questions, we haven't received any this morning, so we can go straight into our business items, which are updates from our transformation groups. And the first updates on our children and young people transition to adulthood. I think that's you, Susie.
It is, thank you, Sharon. I'm going to hand over to Helen. Helen Sweeten's joined us today, who's our still newish joint assistant director, and she's going to present this this update today. So if I hand over to you, Helen, is that okay?
That's great, Susie, thank you. I am going to attempt to share my screen. So I can no longer see you. If somebody could just indicate whether or not you can see that.
Yeah, we've got that, Helen.
So the first thing that I'm just going to update you on is what's been working well in relation to the place plan around children and young people's transition. And you'll see straight away that the Prep for Adulthood board is now in place, and that is providing local leadership. I've joined that board as joint chair with Ian Spicer from Adults, which gives a really good, robust support to that group to really make the progress that we need. And it also links it intrinsically with the work across education and health. We've secured additional investment to develop, implement and embed the pathway to support transitions for young people with diabetes, and that now provides us with a good practice example to roll out further pathway development. And as part of the Recovery and Reset agenda, we've got some recommendations around how reviews of education, health and care plans, which include a health contribution, can be developed, particularly for preparation for adulthood as a key priority.
Helen,
the assistant, yeah.
Helen, sorry, just to interrupt, but the presentation itself is just on the front sheet. It's not actually. So you might want to just do it as. Oh, sorry, it's gone. The front sheet was coming up, but it just wasn't doing the presentation. So.
Okay.
Helen, if it's helpful, I can probably just share the PDF document, which is the bringing together all the slides, Chair, and we can just go through page by page, which is a similar thing. Do you want me to try to do that?
Yeah, I think we're a little bit less familiar with Zoom these days, so that might be helpful, Ian, if you don't mind.
Okay.
Well, while Ian's doing that, just to save time, I can continue taking us through the document. The slides are very brief, so the next positive thing that's happened is that our assistant director, now director for adult care and integration, housing and public health, and the workforce lead for Rotherham has now been appointed to sit on the newly named strategic employment and skills board, which we've already seen some significant progress for our young people as a result of that. And the QDOS Hub Working Advisory Group met on the 12th of January, and representatives for Preparation for Adulthood board and our special schools have been invited to join that group. And in addition, the CCG and TRFT have committed to additional designated clinical officer resource to support our PFA work. In relation to what we're worried about, which would be the next slide, the Joint SEND inspection did identify some areas for development. So we know that preparation for adulthood was identified as a serious weakness in Rotherham, which is unfortunate because there is a lot of really positive and robust work. But what we do know is that in terms of coordination, our ability to ensure that that is consistently available to all young people as they transition into adulthood is still an area for development. And many parents and carers told us that they didn't know who to turn to for help and support. We also know that linked to that, the valuable information that is included in the local offer is underutilised, and in particular for preparation for adulthood children, that's creating a barrier to them preparing themselves sufficiently. The impact of the COVID-19 pandemic caused us a little bit of a worry in terms of reduced capacity, particularly within our health services for any developmental work from March 2020. I'm pleased to say that that's changing now as we appear to be coming out the other end. And there are now a number of overlapping priorities from the integrated care system, the local area SEND inspection, the written statement of action and place board. So I think there is some strong work that's needed across place to make sure that the focus on PFA improvement is cohesive across all of those strands. So in relation to what we're hoping will happen next, and our ask really of place board today is we want to align some of our actions. So we know the local area is required to produce a written statement of action, and that has now been submitted to Ofsted and agreed. And what we want in terms of preparation for adulthood is to ensure that there is sufficient resource to address our priorities. So we would like to align the new actions in the place plan with the actions that are in the preparation for adulthood board, and that will support long-term cohesive approach to this area of focus. We also would like to make sure that that transition to adulthood elements of the place plan are also aligned with the preparation for adulthood board, so we're all working to the same priorities. And that will enable place board, in addition to the SEND executive group, to hold accountability for delivery of this area of SEND improvement. The specific actions in relation to preparation for adulthood: there was an outstanding action on the plan that was in association with the development of pathways, and that is included. We also want to agree joint multi-agency standards and quality assurance for transition in line with the minimum standards. We want to co-produce with health providers good practice guidance for protocols of effective transition. And we want to produce transition pathways for Rotherham's preparing for adulthood cohort for 4 prioritised health services. We also want to encourage attendance of health staff who write education, health and care plans and contribute advice following education, health and care statutory assessments. There are a number of other priorities that are included within the written statement of action, but these are the specific ones that we think are relevant to what Place Board had initially set out that they wanted to achieve in terms of our priorities for transitions. Any questions?
Thanks, Helen. Just open it up for questions or comments. No, just a couple of things just to kick off, Helen. I think it'd be really helpful if at this group we could see the RAG rating of the plan. So understand and agree with things being brought together, but there were some things that we would all want to address that did come out of the SEND inspection. And your point around families understanding what's available, the coordination of that, making it simpler for people to get access to and the pathways. So I think I'd really like us as a board to get that assurance and oversight of the, how those practical recommendations that we've got plans for are actually being implemented, because that's the thing that when we get re-inspected, all of us as partners will be held to account for. So I know we've been in the planning stage. I think now as we get into the delivery stage, assurance this group and support and challenge around the implementation is really where we need to focus. Susie?
Yeah, completely agree with that, Sharon. And I think probably what myself and Helen and colleagues need to do is look at timing to bring the written statement of action as well, so that we get the full view of SEND into Place Board, and we can just sort of ensure that everybody's well sighted on it. Completely agree with the PFA aspects as well and transitionals.
Yeah. Any other comments from any? Sorry, Helen, you wanted to come in.
Did you want me to respond, just to respond to your initial comment, Sharon? So the plan, the place plan for transitions, 3 of the 4 actions have been completed, and we've got 1 outstanding action, which was, well, the action had been completed. It was about mapping our provision. Unfortunately, once we'd completed the action, which we did back in June last year prior to me arriving, we've progressed and identified that actually more mapping needs to take place. So the place plan as is, we've got 3 completed actions and 1 that has progressed but really sort of morphed into a new action. I've been working with Lydia George as well as the preparation for adulthood board to develop more appropriate actions to come back to Place Board. I believe, I'm looking at Ian when I say this, it's the June meeting that those are due for, which would give you a really good oversight in terms of all of the actions that have been completed right up to March at the end of the financial year, and then our new actions, which hopefully by the time we're presenting them next board, you'll be able to see some progress, and certainly the RAG rating against those actions. I guess today we just wanted confirmation that we can align those actions and that you are happy with the priority for those actions being the priorities that have been described in our written statement of action that are specifically related to preparation for adulthood.
Makes absolute sense to me, Helen. But colleagues happy to align with the written statement? Okay.
Yeah, sorry, Sharon. Can you hear me clearly enough this time? Yeah, thank you. Yeah, so just happy to provide that support. As previous chair of the PFA board, it makes absolute sense to come in line, and I think, you know, it's important that we do report on the progress against the 4 areas that were highlighted in the SEND inspection. So yeah, no problem with that, Sharon. Thank you.
Good. And then a real focus on the impact, because we might have done the actions, but the real test is, has it made a difference for families and our young people? So as we move forward on the actions, it'd be really helpful, Helen, just to think about the measures that will give assurance to this board that, you know, the actions are improving outcomes for families and children. Yeah. Everyone happy with that? Yeah, I'm getting nods. Thank you, Helen. And well done, keep going. There's some really good stuff starting to come out, and I think we're all passionate about seeing those outcomes for our children and young people actually improve. But we're going to move on to mental health, learning disability and neurodevelopment, mental health crisis and liaison. Ian, that's a long introduction for you.
Yeah, thanks, Chair. So we're just going to focus on the crisis part, and I'll just share my screen again. As usual with this part of the update, Chair, there's quite a number of colleagues. I can see Catherine, Shafiq all around this agenda as well. So again, if colleagues want to add at any point, feel free to do that. But I'll just share my screen just so hopefully colleagues can be guided through. Can colleagues just confirm that's shared okay? Hopefully it's shown for colleagues. Okay, so we just thought we'd share an update with colleagues of some significant amount of work that's been taking place as we've rolled through the pandemic in terms of trying to make our services resilient, enhancing services in relation to crisis and liaison. Mainly this focus in the community side of things. And I think it's important for me just to remind board members that we've done a lot of work in our Rotherham place over a number of years around our acute liaison and crisis service. And again, they're seen as good practice across the region. And actually, the work that our mental health teams have done at the front end of our kind of hospital pathway throughout the pandemic has been significant. And again, thank you to all colleagues that have worked on that. But this is focusing predominantly in that community element. So just to bring colleagues up to speed then, if we can, as I just move my screen around. So what's working well for us on the crisis elements and community pathways? Colleagues will be aware that we launched, working in partnership, our MBC in partnership with the CCG, the Cooth Digital Mental Health Platform. That went live in November and has received some really good positive feedback. Again, this transitions across children and young people and adults up to the age of 25. So a good piece of work there. We've commissioned an ICS digital 24/7 online mental health platform for 18 plus. And that service will go live in February to March 2022. And again, a really good resource for people that need to tap into information at their point of need. A key theme from our work more recently has been the significant support and welcome support from our voluntary sector partners and Voluntary Action Rotherham. We've done a lot of work in terms of working with Shafiq and colleagues with regards to managing grants in our system, which really targeting at those kind of vulnerable individuals and small grants out in that community setting to make hopefully our voluntary sector more resilient, but also targeting where we can with regards to mental health and support. And we just flagged there the number of grant applications that we've taken through, 39 small grants, which we're managing on our behalf. So we think they'll have some really good support for us. One of our gaps in need across the Rotherham place was around kind of identifying safe spaces in terms of where people can go in their element of need of crisis in the Rotherham place, which might not be in statutory services. So we've just come to the end of the procurement around Safe Space, so that will go live. And we'll probably bring an update back on that model because it is a new model of working in the Rotherham Borough as it embeds. You've heard before, but it's just to keep colleagues up to date with our listening ear bereavement service that we commissioned early in the pandemic around bereavement support for individuals in our system. And that is currently commissioned until June 2022, but we're reviewing that pathway at the moment and we'll take action accordingly. As many colleagues will know, we've had seasonal pressures money that's come in as part of what we're calling it seasonal pressures, winter pressures money, and hospital discharge funding. And we've actually absolutely used that across our system to support across the mental health pathways. And we're just illustrating there where we've done that via VAR, Samaritan, Bipolar UK, etc., all with a view of just enhancing our capacity. We've taken forward a Section 12 solutions app. So this is where we use an application to ensure that we can get timely assessment of people in mental health crisis via professionals. And again, that's been rolled out as South Yorkshire footprint and again has been received really well. And finally, just on this slide, again, further integration of our mental health and crisis liaison service, and again, working across the council and RDASH, and there's further work to do around that, which we'll come on to in a second. Okay, so things that we're worried about in this area, probably not unsurprisingly, we are seeing further demand on our services, both through winter pressures, COVID outbreaks, and removal of protective factors that have been around individuals over the period of the pandemic. So again, that demand in services, on services and in our system is significant and continues to be so. The availability of Section 12 doctors to undertake assessments of people in the community and in crisis is a challenge for our ICS and others, so we need to keep working on that in terms of, and that leads on to the point around workforce recruitment and retention challenges across this area. We do need to continue to do our work around pathways across RDASH-TRFT. We've had plans in place around Care Coordination Centre, managing some of our crisis elements over a number of years. And again, I think we need to continue to work on that to really refine that pathway accordingly. And again, as we review pathways within respective partners, that final point there, we need to ensure that the impact of those reviews is managed accordingly within our place and in the spirit that we need to take them forward. So finally, just in this space, what needs to happen next? A couple of services need to be mobilised, as I've described in the first slide there around Safe Space and the ICS online digital platform. We'll continue to roll out COOF across the Rotherham place. The continuation of our smaller grant schemes, but increasingly the evaluation of those and the effect that they're having in communities will be absolutely key. I mentioned that our bereavement support service that we've commissioned and has been really well received comes to an end in June. So again, we're currently scoping out what the future model looks like, not just on that service, but in bereavement provision across the Rotherham place. We think there's some gaps in there. And again, working closely with public health and other partners to work through those. We know that we've got pathway redesign on social care crisis pathways, and again, we'll take that forward. There is a dialogue to be had around care coordination and crisis out of hours and helplines, etc. So that will be a priority in the coming months. We have supported and have received a really comprehensive business case around enhancing children's crisis services delivered by RDASH. So there's full support for that. So we really need to mobilise that accordingly. And again, we need to continue to look at the crisis front end. So as I started this presentation, acknowledging the work that is happening in the front end of our hospital setting, there is still, as you'd expect, ongoing review and work to happening there. Just this final bullet, and then I'll come up for air chair. The wider ICS work continues. So we've mentioned Section 12 doctor provision. I think the sustainability element of that has got to be looked at across South Yorkshire. Ongoing work with the Yorkshire Ambulance Service there in terms of mental health support and mental health professionals in our ambulance control room so we can signpost individuals accordingly. And again, the ongoing discussion around 136 process, which is in terms of keeping people in safe spaces linked with the police. So lots happening, and just when you drop these things into 3 slides, you can see phenomenal work that colleagues have been trying to take forward in our place and wider system as we've driven through the pandemic. Thank you, Chair. I'll stop there and happy to take any comments, or if Shafiq or Catherine want to add, please do so. Thank you.
Thanks, Ian. Catherine, Shafiq, do you want to come in?
No, nothing really from me, Sharon. Just very comprehensive. So thank you for that, Ian, and thank you for your comments as well about the huge sector-wide response that we've seen from mental health as well to support the pandemic. Perhaps, having said no, I'm not going to say anything. I'm now saying stuff, aren't I? So just perhaps the one thing to reiterate from what Ian was saying, and that is about the availability of Section 12 doctors and how that supports the operation of the Section 136 suite. So that is a pivotal issue for us in terms of a smooth crisis pathway. And it is, as Ian says, an issue that is facing all CCGs and mental health providers up and down the country. But we've got to find a way forward on this, because it is a proper rate limiter in terms of our ability to be able to respond promptly and safely as a sector and as a place to the situations when people are in real need.
Come back to that in a minute, Catherine.
Thank you.
Thank you. Shafiq, anything that you wanted to add?
Yes, thank you, Sharon. Just to echo what Ian has said, I think what's been really positive is that we've always done it to a large degree, but actually we're looking at mental health not just as clinical pathways. We are thinking about and looking at what the community offer is and what the prevention and early intervention signs are. And those small grants out to community groups haven't just been grants out for anything and everything. We've asked groups to think about the sort of offer that they're providing, which supports resilience and good mental health in local communities. And that's really positive. So the more we can build on that, the more we can try and keep people out of clinical services, which is really what we want to do.
It's really good. It'd be really good to see if we can evaluate the impact this year and see what that looks like. Just on the point of the Section 12 doctors, have we escalated that formally through the ICSE, and is there a system that we've actually connected to, or is that something we need to formally do from the place board? I don't want, if you know, it is really important. So we need a formalised way of escalating it. If we've already got that, fine. But if we've not, we just think we need to do that from the board today.
Yeah, my view on it, and Catherine maybe a little bit closer from a provision perspective as well, is that it's absolutely escalated into the wider mental health and LD kind of board at a South Yorkshire level. As Catherine says, it's probably a national issue as well in that space, Sharon. So I think there will be local things that we'll want to continue to reflect on in terms of, can we do things differently now rather than place on what's in our control. But it is a very challenging area in terms of getting that workforce in place to respond, and it's the timeliness of that response, isn't it, Catherine, that's really key. Thank you.
Catherine, do you want to come back in before I bring Councillor Roche in?
Please, thank you. And yes, it's part of our the Mental Health Alliance that operates across South Yorkshire. It's an issue that all of those providers, there's 5 providers, it's something that we're all very concerned about. We do work as a collective through the ICS in terms of establishing, again, referenced in Ian's slides about the revision to the Section 136 standing operating procedure. We are trying to much better align the way in which patients, or citizens rather, actually flow through that part of the Mental Health Act. We're starting to get more of a performance focus around mental health at the ICS, with a number of key performance indicators now being reported on. And certainly in discussions I was having yesterday with the programme manager for mental health, we are going to talk to NHS England about asking them to start adding more KPIs to that, so that all of the ICS is aware of the pressure, because it does have significant impact across all sectors. So if we have a lack of a Section 12 doctor, which means that we can't then undertake a Section 136 assessment, it means we're tying up police, we're tying up staff who aren't working with other patients, we're potentially If we're in a health-based place of safety rather than a 136 suite, we're taking up A&E facility and space and capacity. So, and apart from the fact that the citizen has a really awful experience, so we're looking to see if the ICS will start providing more of a benchmarking of activity across the whole of the crisis pathway, so that we can start to use that as a means for driving improvement.
And Catherine, it goes without saying, if it feels that more traction is needed and that our support as a board would enable that, then we'd be very happy to formally write in to make sure that it is moving. Obviously, if it is moving, really happy. But if we did need to do that, I'm sure we'd all.
Brilliant, thank you.
I bring Councillor Roche in and then Dr. Mutu.
Yeah, just a very brief point, minor point, just to say that the small grant scheme I thought was fantastic, very well received, some excellent applications, and I'm sure, well, we obviously need to wait for the evaluation, but from what I saw from the applications when I was one of the educators, no, it seemed to be some very good stuff coming through. So I hope it can be repeated again, but my only learning point is most of them seem to come from central Rotherham areas. We just need, if it is repeated, just to sort of see how we can extend the knowledge base or information base so more people can potentially apply.
Thanks, Councillor Oakes. I'm sure those comments are noted. Councillor Mutu. Councillor Mutu. Dr. Mutu. Get the preface right.
Thank you, Sharon, for that new title. Sharon, just on this Section 12 doctors, there are quite a few who have retired recently who were Section 12 approved. I'm just wondering, as a place, whether we could offer some retraining or how do I put it? I think it's retraining or trying to get them back just to do that, whether that can be funded by the place. If that is possible, I could get the Federation to look into that. Thank you.
Chris, Ian, is that one that yours?
Chair, can I just suggest that I just take an action on the minutes just to pick that up outside with Dr. Mutu directly and then link in with Catherine if required. Is that okay with colleagues?
Yep. Great. Thank you. We'll note that in the minutes and see where that conversation takes us. Is that okay, Dr. Mutu? Good. Any further comments? Thank you for that, colleagues. It was it's good to see that moving, but we all want to make sure that that patient experience or citizen experience, as you said, Catherine, improves. So definitely one that we need to keep an eye on and with our colleagues at the ICS. Move on to Michael and what will be now Ian, urgent and community care, urgent response.
Thank you, Sharon. Would you mind if I invite my colleague Steph Watson, please? Steph's our urgent and community place programme manager, and Steph is really well placed to run through these next slides.
Yeah, that's great. Welcome, Steph.
Thank you very much. I'll just share my screen, hopefully. This one, I think. Is that coming up? Does that come up?
Yeah, we can see it, Steph. We can see your first slide.
Great. I can't actually see the slide now, so I hope this works. So thank you for inviting me along. Has that moved on to the second slide? Because it's not actually showing on my screen.
Just move it up a bit, Steph. We can see half of you. What is the urgent and community response? There you go. It's full.
Lovely. Thank you. So just by way of introduction, the urgent community response is a new national mandate. It's for our community urgent services who need to respond to referrals within 2 hours from the initial referral through to the initial assessment or contact. And that's coming in from April 2022. There's a threshold that will follow in December, which is that we'll have to meet the standard by 70% of the time. And then further to that, in 2024, there'll be a 2-day reablement standard. And the requirement is to have an MDT team working across the whole borough at a minimum of 8 to 8 p.m, 7 days a week. The pathways need to be aligned with our emergency services, primary care and discharge teams. And to monitor all that, there's a new national standard coming in where we have to submit a mandatory data set, which will be published monthly from this April, and it will provide comparator statistics akin to the A&E standards, so a fully transparent data set. And it's quite a complex data set, but the key things that we're reporting on is the number of referrals, the care activity, and the response times. So in terms of what's working well, well, the good news is we already have a borough-wide service that works 8 till 8. There's been national investment monies to help us to deliver to the standard, and the project is currently on track. We've mapped all the as-is processes, we've developed new ways of working, and we've done some system development work, particularly around clock start and stop times. We've been training staff over the last couple of weeks, and our first service went live on Monday, and we'll be rolling it out to the other services over the coming week. We've been doing a lot of work with our partners in 111 to develop our directory services. And this is where when you contact 111, they use an algorithm to direct a patient to the right level of care, the right pathway. So it's really important that those algorithms are aligned to the right service. So we're doing a lot of review work on that, including looking at the pathways to our emergency centre. And we're also developing work with YAS around avoiding unnecessarily conveyances to hospital, particularly around falls. We know when particularly frail and elderly people fall, they tend to be taken off to A&E as a precautionary measure. And actually all the evidence is that if they can be supported, monitored and cared for at home, there are much better outcomes. So we're drawing on good practice from elsewhere in the country and for our own resources in Rotherham to work out pathways where we can best support people at home. And that includes working with the voluntary sector, Age UK and Rothercare, as well as our own nursing and medical services. I mentioned that we've got some national monies to invest. We commissioned a company called Attain to develop a capacity and demand tool specifically for the community. Because whilst we know where there's blockages and issues with capacity, we haven't had the level of granularity to understand exactly what resource we need where, and if we make changes in one part of the system, what will the impact be in another part of the system. So this has been a really helpful tool that's been developed in just a few months, and we're already using it to help us make decisions around investments. So for example, the current contracts are about to end around some of our community beds that we put in place over winter, and we're using the tool to identify how many beds we might need going forward, aligned to some predictive models around COVID as well, because obviously balancing what was normal and the impact of COVID on demand for community beds is not an exact science at the moment. And the more we invest in community beds, the less money there is to support people at home. So it's really important to get that balance right, because again, the national evidence is the more people we can keep at home and support at home, the better the patient outcomes. So in terms of things we're worried about, it is a national data set, so it's the first time it's been transparent in this way. So we've keen to know how we benchmark, So we've been working locally with ICS partners and with the national team just to get an indication of where we're at. And as we clean the data going forward before the April deadline, we'll get a more accurate picture on that. So that's a risk that we're monitoring. Like all the other projects in place, we have struggled with system pressures and the impact of COVID. I think we really need to congratulate the key frontline staff and the clinical leaders who have really engaged with this project and made time. Just an example, this week we've had people coming onto training sessions from their days off so that they were ready for go live this week. So a really good effort on that. And the community teams are excited about this, supporting patients at home and clients at home is what they do. So they're really pleased to have the profile that's been missing in the past. Further challenge, as Ian was mentioning, with mental health, recruitment to additional roles. Funding's currently, the national funding is currently non-substantive, though we have been told there'll be more monies over the next 2 years. We've yet to have that confirmation in writing. It's difficult to attract to non-substantive roles. And of course, because it's a national project, we're all fishing in the same pool. So we've been trying to mitigate this through RMBC and TRFT and made some of the key roles substantive based on vacancy factors elsewhere. And we're developing a recruitment strategy across health and social care, working at place and working with the ICS to really try and make roles attractive, look at generic roles across health and social care, look at career progression, work with local schools, colleges, universities, as well as job centres. So that's joining up with a piece of work that's already underway and targeted itself at research and response as well. So in terms of next steps, we've got a period of data cleansing through till April. We're reviewing our referral routes in and out of pathways, and we've got a project underway to review the role of the Care Coordination Centre and the integration with our MDT teams. And we'll be, as part of that, we're developing an MDT community hub to support this work, particularly around admission avoidance and discharge pathways to support people at home and in the community. And as I mentioned earlier, we'll be reviewing MDT working and resourcing requirements. So, any questions?
Thank you for that, Steph. That was really helpful. Any questions to Steph? Ben?
Thanks, Steph. It was really good to hear about that. I guess just one from me around sort of the outcomes of this and how they're going to be monitored for inequalities, because I'm guessing there will be big differences in people's resources and ability to be managed at home, and how we look at that and how it plays out across the system. But also, yeah, how do we invest in the right support for those people who are isolated or unsupported at home to stay at home and avoid admissions where we can, and as you say, improve outcomes that way.
Yeah, it's part of the national dashboard, Ben. We're doing some shadow reports, but at the moment we don't have all the coding at that level of granularity. So it's something that after the initial go live and meeting the immediate requirements, we will be developing and building in, and through the work with yourself and Becky and Alex, we'll make sure we tie all of that up and get the local and national data that we need.
I think Ben seems very pleased with that, Steph. It'd be good to see that data when it starts to come out. Maybe take some of the learning from other areas. Any other questions for Steph? Have we got a date, Steph, you know, on the next steps? And it talked about the community hub.
We're just scoping that at the moment, Sharon. So I think it'll be a phased approach.
Right.
So we're starting with nursing therapies, and we've got 2 members of the reablement team who we're in the process of co-locating to Woodside. So that's our initial start, and then we'll grow it over the coming year using the national monies when we've got that confirmed.
Thank you. Any other questions for Steph? Good to see progress being made on that, Steph. Well done. And please pass on our thanks to the teams that are involved in it. I know doing this at the moment has been quite challenging when we've been dealing with everything else, but it's really, really important. So glad to see that it still has been able to be prioritised. So yeah, please do pass on our thanks.
Thank you, Sharon. I'm just going off to the project meeting now, so I'll disappear, but thanks for the opportunity to talk to you all.
Thank you. Thanks, Steph.
Bye.
Okay. Shall we move on to item 3, Ben? Enabling group update, prevention and health inequalities.
Yeah, it's my screen sharing, Sharon.
Yeah, we can see the first title page, Ben.
Brilliant. So yeah, prevention and health inequalities enabling group had, I guess, stood up earlier in the year, had a little bit of a hiatus with COVID and also with the recruitment, some of the support posts, but starting to motor now, which is really positive progress. So where we're up to and what's working well at the moment. So we've now got a draft prevention and health inequalities strategy and action plan produced, and it's got these 6 priorities, and I'll not go through all of them in detail, but just highlighting, I think the first one and been put at the top specifically as priority number 1 is around that understanding of health inequalities across the borough and putting the population health management focus to the forefront in what we're looking to do. So everything we do wants to be data driven and data led. And you see from the next bullet as well, we now have a health inequalities data subgroup that previously existed as a sort of group on its own, now reports into the health inequalities enabling group. So it's got the governance link, and that will really drive that work forward as we move through. Second one is around harnessing partners' collective roles as anchor institutions, and I'll come on to that in the next couple of slides because that needs quite a lot of work. Third one is developing the healthy lifestyles prevention pathway. So what we've recognised is there's a lot of work in prevention that goes on across Rotherham, some really good work, but not all of it is well connected, and the referral routes differ. And so actually what we need is more of a consistent pathway through and to make sure the right people are getting the right access into the right sort of preventative approaches, whether that's advice and support and people having the ability to self-manage, or whether it's referral through into some of the voluntary sector services, some of the social prescribing, or some of the public health lifestyle services. And that also aligns to the project we're currently undertaking in public health around the recommissioning of our lifestyle services and health checks, and making sure that fits with a new pathway approach. Prevention and early diagnosis of chronic conditions, so particular focus around cardiovascular disease, cancer, early diagnosis and respiratory disease, and also mental health around making sure people are into the right pathways and getting early preventative support. Tackling clinical variation, so again, linked to that prevention early diagnosis, it's then once you've got people into the system, making sure they're getting the right management, getting all of the QOF pathway delivery within primary care and getting through into secondary care. And again, a number of projects coming across that. And then one that we've also kept in there is advocating for prevention across the system, and that's in part a recognition that the group's work is very much focused on health and social care delivery and what we can do for prevention there. But everything we come to, there is a wider determinants of health outcomes or issues that are adding to the problem or creating the problem. And what we didn't want to do was just say that's not our remit and close them off. But also we don't want to take responsibility for solving those as a group that's focused on health and social care. So that advocacy is pushing things back into Health and Wellbeing Board, other places, to make sure we're using the voice of the system to push for things that we know can change in Rotherham, but may need people outside of our group. Mention the subgroup, and then governance links around named executive leads for all of the partners around health inequalities being confirmed, and just really making sure that it's not just our subgroup and enabler group that's taking this forward, but actually each organisation's got an executive lead with a role to push that agenda within their organisation as well. So what we're worried about, I think, as I said, the anchor institution agenda is really broad. We need to determine actually what are we going to focus on as a place at the moment and how we take that forward. We currently have the procurement group that's looking at sort of anchor institution and social value across the system, that's doing one part of the anchor institution role, but there's lots of other parts that aren't as well developed as that and need further maturing. And I'll come on to that again in the next slide. As the ICS continues to develop, it's making sure our place activity aligns to some of the national directives and some of the ICS level directives, but also that the ICS is supporting us to deliver what we've agreed is priority in place, and started to have discussions with Lisa Wilkins and Lisa Kell at the ICS around how place and the ICS link together. And there's a design workshop for the ICS's population health management, health inequalities work this afternoon, which again will help Rotherham sort of make sure our place priorities are at the forefront for what we want to do, and we're contributing to the wider agenda that the ICS wants to deliver. And then I think the other area is some areas of engagement that still need to be developed, ICS being one of those that I've already mentioned, and the other one being primary care and primary care networks particularly. I think there's a real role for them in the clinical variation and prevention pathway work, and we just need to really cement our relationships with all of the PCNs and with primary care more broadly, to build on those links. What needs to happen next? So next steps in terms of the plan is to finalise and sign off the Prevention Inequality Strategy and Action Plan, and that'll be reviewed at the Enabler Group in February, and then that'll come through Delivery Board and to Place Board again. And then based on the final version of that, developing an outcomes framework and dashboard, so we've actually got clear metrics and a clear ability to measure delivery and track where we're moving forward against those ambitions, and that will be a role for the data and data group that's been set up. On the role of anchor institutions, so I think what we're wanting is to get a better understanding of what's already happening in our various organisations around those anchor institutions' role, what our agreed definition and priorities should be, and move that work forward. So in March's meeting, we're going to use that as a workshop session to particularly focus on the anchor institution work, and hopefully shake out of that what the actions should be in that area. Continuing those conversations, as I say, with the ICS, making sure that our prevention inequalities enabler group priorities feature well with the ICS, linked to what Rotherham, Barnsley and Doncaster, Sheffield, Barnsley and Doncaster are doing, and yeah, that we're getting the right support from ICS level to deliver what we need to deliver locally. And then, as I say, further engagement around primary care network, and particularly with the clinical directors, but also other stakeholders and elected members, to make sure once we've got our final action plan that it's well known, well supported, and that we're getting a wider collaborative in terms of delivery. Stop sharing that.
Thanks, Ben. And this was kind of a newer addition to our programme, so it's really good to see that the activity is underway. And I know that this was an area we all wanted to see prioritised, so good to see that traction start. Any questions or feedback for Ben? Michael, sorry.
Thanks, Sharon. Yeah, thank you, Ben. Really helpful. Just so colleagues are aware, I'm the lead director for Health and Equalities at the Rotherham Foundation Trust. We have a task and finish group that's chaired by one of our non-exec directors, and Ben sits on that group with us, so we're very much aligned. We've set up a project group looking specifically at this and have a number of actions to take this forward. So we're also focusing on our influence as an anchor institution, and we're also gathering as much data as possible to see what the conclusions are from that data. So although it's only been running a few months, it's in its infancy, it's starting to get some traction, and I'd be happy to feedback at future meetings.
That'd be great. Thank you, Michael. It's a good offer, and one I'm sure that we can all learn from in our own organisations. Any other feedback? No. Gok, sorry, Dr. Mutu.
Thanks, Sharon. Thanks for that, Ben. I think really very good to know you guys have picked up well in this project. Now, getting clinicians, I think, is vital in this. You do need them. It doesn't have to be CVs because they are really struggling for time. But what you need is probably interested clinicians. A bit of information to GPs to see if they could step up or come forward for this would help. I find it very difficult to make it to a meeting because it's been happening where it's been clashing with my clinical time, and my priority still is with the patients, and with the COVID, especially with staff shortages and capacity being really poor and shocking at times. Just couldn't give any input. So now with things easing off, probably there'll be more GPs willing to step in. Thank you.
Yeah, thanks, Cox. And I think, yeah, we do just need to follow up that conversation, work out how best to involve clinicians and as you say, fit around clinical time and make sure we've got that voice into the group.
Okay, thanks, colleagues. We move swiftly on. Ian, place plan priorities, Q2 update.
Yeah, thanks, Chair. I've just got one eye on time as well for you. So this is a bit of a report by exception, if that's okay. Okay, yep. Chair. So, and it is Q2, so it might feel like, why is it Q2 when we're pushing towards the end of Q4? But just to keep colleagues up to speed, is that we said we'd bring through quarterly updates on all our priorities that we agreed as part of the place plan. These are presented before colleagues today, and obviously it's been impacted by the pandemic in terms of timing of place board and how we've reported through. I think what you will see in there, just a couple of things. There's one of the children's element, which is the neurodevelopmental pathway or our autism pathway, which is flagging red in both quarters. If I was sat here now for Q3, that would have changed because we've made significant decisions in Q3 around investment and service redesign, which is referenced in that document. So Place Board will get a full update on that proposal in line with some of the send work we're doing. And then secondly, if I can, Chair, the other areas where you're seeing things that just might have moved from amber to red mainly reflect in the areas where we intended to recruit workforce over that period, and actually because of system pressures, we've either not got to recruiting the workforce, or where we've gone out to recruit, we've not been successful. There's a couple of references there, like for example on IAPT and some things in primary care around additional roles, which are new roles in the system. So it's not the priorities not being taken forward, it's just reflecting where we got to at a point in time. So those are the couple of things I just wanted to mention under this, but again, we'll keep reporting back through. We'll do a Q4 summary as the plan to bring back to Place Board accordingly. Okay, thank you.
Thanks, Ian. And thanks for the explanation there. It's probably one we'll want to pick up at the next quarterly update, isn't it, around how we've managed some of those workforce pressures. Any comments, colleagues? No? Thanks, Ian. Thanks, Lydia, for all the work that's done on that. And it will stand us in good stead as we start to get, hopefully, back to a different way of working over the coming months. Then system pressures, any members want to escalate today? No, challenging, but getting on with it, I think, is the key message. Okay. Action log. I note we've got just one that's been deferred, so I think we're just looking at a date, aren't we, around that? So I think if we can come back to the next meeting with a date on that one, that would be good. And then any communications to partners. Gordon, anything that we need to pick up on today?
No, I don't think so, Sharon. I've not picked on anything in particular. I think probably just need to have a discussion out of here just about how we pick up. Previously, we agreed at the board that we'd do 2 or 3 points to feedback to partners. So I think we just need to discuss how and when we start doing that again. But just noted that down, and I think we'll take that offline if that's okay.
Yeah, that's fine, Gordon. And now we're back into meeting in this way. We can get it back into play for the next meeting. Yeah.
Yeah, absolutely.
Yeah, super. Any risks or items for escalation? Just noted, Catherine, that one's from earlier is in the back of my mind. We'll come back to it if we do need to escalate it, but we're not formally doing that at this time. So I don't think there is anything today. Just check with colleagues. No. Okay. And then for our next meeting, we've got we've got our development plans update, a review. Oh, Lydia, we'll just confirm that before the next meeting around the IT services, provider collaborative updates and the transformation group updates. And our next meeting will be on the 2nd of March, colleagues. So I look forward to seeing you all then, and hopefully a bit more of spring and people can get out and enjoy the weather. Take care, colleagues. Thank you for today.